helpful for them. So at this point, I am turning it over to Teresa. Our WISE task force really helped put all of these together. They divided and conquered. So each of them took a week or two and got a guest speaker and put together kind of the program for the week. So Teresa is responsible for tonight and recruiting Dr. Bob. So she's going to do the introductions, although I'm not sure Dr. Bob needs too much of an introduction.
Not too much, right? He's afraid to say no to me, so it worked out really well.
That's true.
So Dr. Bob, grew up in West Hill, which is where many of you have visited Koinonia. So that was really his home neighborhood that he returned to. He's a graduate of SUNY Albany, so he's got a little of the purple in him as well. And then I met him when he was a first-year medical student at Albany Med, and he kind of stood out to me because he was the first non-traditional medical student I had met at that time, and just was so impressed with him as a medical student already, as a mentor and a teacher and a leader. Probably the only man who could ever get me to pack my bags the first time and go to Africa. So I had that wonderful experience with him. And then in about 2000, he kind of walked away from his cushy job at Albany Medical Center and began Koinonia Primary Care and his commitment to the vulnerable population in Albany. And it kind of goes along with his life of caring for those in need, both abroad and at home. And I get to see him be an incredible mentor and teacher to our medical students and kind of grow compassionate physicians that go out into the world and shine their light. He's also married to a rock star named Leanne and has amazing kids who are also out there doing amazing, amazing work, and just really proud of the connections we've had with him with Journey throughout the years, and that you guys have gotten to see just a little bit of his light. So without further ado, bring on the depression and anxiety, Dr. Bob.
With pleasure. Yeah, I want to first start off with a huge congratulations for you guys for tackling these issues. These issues in terms of the stigma associated with mental health diagnoses, and especially sometimes, quite honestly, the treatment of the individuals afflicted with mental health issues by the church has been abysmal. And excuse me. And so congratulations. I also want to say publicly thank you to Journey Church. You guys have been an amazing partner in terms of throughout the years, helping us care for the marginalized population in the inner city. And you've been there everything with your time. And so, I'm really happy to be able to give back a little bit in terms of helping you to maybe do this job you've set out to do in a little bit better way. So let's talk about depression and anxiety. First off, depression in the United States, there's somewhere between 16 and 18 million people at any point in time who are suffering from clinical depression. That's fairly close to 10% of the adult population. That's a lot of people. I'm sure there's probably not a person here who, if you haven't experienced depression for yourself, you probably have a family member or a friend or someone, or maybe, crazy old Uncle George or something like that who has suffered from depression. The World Health Organization classifies depression as the most prevalent chronic disease on the planet. So this is not just an American phenomenon, which some might think because, some of our culture and some of the way we do things and so forth. This is a worldwide phenomenon. And if you look at prevalence rates, or the prevalence of the disease, major depressive disorder in a population, it's pretty consistent worldwide, across all cultures, across all ethnicities. It's pretty consistent, even in Africa and places like that. So, we live in the times of depression. These are our times. And we need to kind of, as a church, to kind of stand up and see what's going on out here and help with this disease that affects so many of our friends and neighbors and maybe even ourselves. Tell you a little bit about my story. I grew up in a home where my mother was mentally ill. And I remember when I was a 10-year-old boy, when the people came to take her away to the state mental hospital. It was one of the most traumatic experiences in my life. And so I've seen firsthand how not only depression, but other mental illnesses can wreak havoc in terms of a family, in terms of bringing things like shame and things like that into people's lives. And it's really a terrible thing. And I've seen firsthand the stigma associated with having a disease that involves the brain, as opposed to no one really has a problem if if you mention at a party or something that you're diabetic and you take insulin, or that you're asthmatic and you need an inhaler, rescue inhaler or something. No one seems to have a problem. No one considers you less a human being if you report those kinds of conditions, those diseases. And yet, somehow, when it comes to mental health disease, if you report that, oh boy, people want to stay away from you. They don't want to go around you. Some people think you've made it up, like, you want to feel this way, and so forth. So it's really stigmatized. And unfortunately, what happens is people, because of the stigma, don't seek appropriate treatments. I remember caring for a young couple many years ago now when we first started, but this still sticks in my mind. This was a young man my son went to high school with and was in our house, it was a friend of my son's as a young man. And, so he grew up kind of in our neighborhood where we lived at that time. And, he married this lovely young woman and they were just starting out, and she was terribly, terribly, terribly depressed. And the irony of the whole thing was I had the ability to help her. And because of their particular faith and theology and so forth, they refused to take the medications. And so I think, now I never saw them after I offered those medications in a way of treatment to them, but I suspect that she would not do well. And a lot of that was because of what I consider bad theology, number one, and also this stigma that's out there, even for people who aren't necessarily religious. So what is depression? And Teresa, just keep an eye on the time here, because, I can go on and lecture for a long time. So if I, get out of hand, do something. I don't know what you do on Zoom, but do something.
Yeah, and probably when it's time to shift to questions, I'll do this.
Okay. I'll see that. Great. So depression is involves two things. To make a diagnosis of depression, one has to be either have depressed mood, sad, or the blues, or however they refer to it, for every day for 2 weeks. Okay, so depression is not a bad day. I'm sure everyone in this Zoom chat room or whatever this is called has had bad days, and where you felt down, your mood was down, and I'm depressed. Well, that's not really clinical depression. It has to be down every day for 2 weeks, at least 2 weeks. Now, most of the people I see, it's far longer than that, but it's at least 2 weeks. It cannot be associated with certain other things. So for example, if a family member or loved one dies and you feel down, that is not depression. That's normal. I mean, if someone dies, like mom or dad or spouse or whatever, and you're up dancing and singing, that's mental illness, most likely. But feeling down when bad things happen is not depression. Okay. And I have many people that say, Doc, I don't know, I have all the money I need. I have everything. My needs are met. My relationships are good. I do all the right stuff, and yet I feel depressed. I don't know why. And so what I say to people like that is, you don't need a reason to be depressed. In fact, if you have a reason, it's often not depression at all. It's something else, so it's like a grief reaction, or it's like bereavement when we lose a loved one, or something, some life circumstance, like you lose the job, or your house burns down, or something like that. So depression, you do not have to have a reason. It is not like people with clinical depression decide, hey, today I'm going to be just depressed because I want to be. I don't know one person I've ever, dealt with that said, I want to be there. They're miserable, and most of the time, they want help. The problem is, I like to look at depression as really this incredible energy sink. So they don't have the psychic energy to really engage in life. And so they can't mount enough energy to deal with their problems. Sometimes people can't mount enough energy to get out of bed. They just, they don't have it. It's not like they decided or they want to, they just can't do it. And so it's like a big energy sink. Now, there are many, many different types of depression. Okay, so it's not everyone is the same. Not everyone will appear the same or have the same kind of symptoms. They all either have their mood down for at least 2 weeks every day, or lose total interest in all pleasurable life activities. I believe God wanted us to really enjoy life, and therefore, if we're not enjoying it, if we're taking no pleasure in anything, we call that anhedonia. You've probably heard the word hedonism, or the pursuit of pleasure. Well, the opposite of that, taking no pleasure in life at all, in anything that you once found pleasure in. So, for example, maybe you had a group of friends that you went to the movies with. And and you're in my office, and I'll say, what do you do for fun? And the person will say, well, I used to have a group from my church, and I went to the movies with them once a week. When was the last time you did that? Oh, I don't know, maybe a year ago. We're talking pre-COVID times here, okay? And why? I don't know. I just don't feel like it. I don't feel like engaging in sex with my partner. Things that they normally found pleasurable in the past, they don't feel like it at all. Excuse me. And so that's depression. But there can be, depressions where people are really, can't have enough energy to get out of bed. And then there's depressions where people are incredibly anxious, and they're all over the place, and they're worried and they're upset, and they're moving and so forth. And that's a depression too. And so probably if we knew more and we looked down into the brain at closer and closer levels, what we call depression is probably a whole bunch of different conditions on that brain level. But we don't know enough right now to get down that close to find that out. There are really good treatments for depression. I tell people there are 3 ways that we can treat this. One is through medicine, one is through psychotherapy or counseling, and another is through both. The best, in my opinion, is both. However, some people, for a variety of reasons, they don't want to engage in psychotherapy, or they can't make the commitment, or it costs too much, or whatever the issue is, or they just don't believe in it. And then other people, as you probably know, they don't trust medicines, they don't want medicines, they don't want anything to do with that. So here's how I look at what to use and how to use it. It's been proven that medicines work, and it's been proven that psychotherapy or counseling works. So they both are effective, okay? What I usually teach the students is, if you were to buy, say, an old house, one of these old mansions down like the old haunted house, you know, and you go into the living room and the wallpaper is peeling off and there's big holes in the plaster and it's just a mess. You don't just buy a gallon of paint and put a coat of paint over that room and say, oh my God, now it's perfect, right? No, you can't do that. So what do you have to do? You go in, you plaster the cracks in the wall, you peel off all the old paper, you prepare everything, you sand it, you get it all ready. Then you put the paint on, and guess what? It looks beautiful. So what's the analogy here? The analogy is the preparatory work, the putting the plaster in the cracks and sanding and getting ready and all that kind of stuff. That's the medicine. That's the medicine part. The finish coat on top of all that and stuff, that's usually the therapy part, okay? And so, you know, sometimes people can't engage in therapy and counseling. They just don't have the energy to do it. They just can't do it. And so they need to be put on medicines to get them to a place where they can engage. The other aspect of it is, you know, sometimes there's time elements involved. So for people, even though psychotherapy is effective, it may take months, even years, before a person is fully, you know, thriving and prospering. Sometimes you don't have that kind of time. So you need something that'll work quicker. And so that's the point of using medicine. And there are many of them we have these days. And they're good medicines and they're safe and so forth. We can comment more on medications lately or in a little while because, you know, some of you may have some issues or concerns about that. Okay, so now let's talk a few minutes about anxiety. So if you think depression was prevalent, what did I say? Some people say 16 million, some people say 18 million. Anxiety disorders, 40 million. It is tremendous. We live in not only depressed times, but very anxious times. About half the people that suffer from depression also have anxiety diagnosis. So there's a lot of overlap here. And there's a lot of overlap with all these kind of psychiatric diagnoses that people have similar symptoms and so forth. So just be aware of that. They range from, you know, most common is probably social phobias. So the fear of public speaking, the fear of leaving your home, agoraphobia, you know, lots of fears like that are relatively common and so forth. Then you get things like obsessive compulsive disorder, post-traumatic stress disorder, you know, so there are many facets that are anxiety disorders. Now, one of the things, like I said about depression, you know, depression is not a bad day. Anxiety is not an anxious or worrying day. So I tell the students this, I can make anyone in this room anxious. There's an exam tomorrow, okay? They're anxious, okay? I can do that easily. Now, do they have an anxiety disorder? No. So how do we determine then when anxiety becomes a diagnosis versus just, you know, a very anxious or worrisome day? Well, when it begins to interfere with someone's life to the point that it becomes detrimental to them, significantly detrimental. So, for example, it's affecting their marriage. It's affecting their ability to get up and go to work. It's affecting their ability to have relationships with friends or to go out and do things that are pleasurable for them to do. At that point, it becomes more of an anxiety disorder, a diagnosis. So as a group of non-physicians, I assume probably most of you are not doctors. What are some things I could share with you that I think you could do that would really help people that experience this? First thing, you've already started. You're welcoming them into your community. I mean, that is tremendous because when people are stigmatized, they tend to isolate. And so they tend to and there's a lot of shame associated with some of these things. So they isolate because they feel in some ways that no one wants to be around them. And so just by inviting them into your presence, and not just, hey, do you want to come to church on Sunday or what? But be a little bit more of a pain in the butt about it, really encourage them to engage and so forth. And when they come, don't treat them like a different person. Treat them like you would want to be treated if you were coming into a new place. Make them feel at home and welcome. And sit next to them maybe, or give them the preferred seat or whatever it is that makes them feel like an important person. So you want to build up their personhood because in many regards, it's been torn down as a result of this particular disease that they're suffering from. So that's one thing I would suggest. Another, be very, very slow to give advice. I don't like to give advice, and I spend all day doing it. I say that rather facetiously, but the point is that you have to be really, really careful. Especially, you want to refer the professional stuff back to the professionals, because you can get a slanted view of things. So, for example, your brother-in-law had depression, and he took this miracle drug, and he's no longer depressed, and he's great, and he's the life of the party, and et cetera, et cetera. And so you say, hey, my brother-in-law, has the same thing you had. You don't know that, number one. Okay, it could be significantly different, although it appears similar on the outside. So, don't say, hey, try this medicine or whatever. That's probably not a good idea unless you go with the person to the doctor's office. And that's something you could consider doing. That's a little bit more beyond, but some people could really use an advocate and so forth. So that's something you can think about. But generally, try not to give advice, but be present for the person. Be accepting, okay? These are people, you cut them, they bleed. They, regardless of their diagnosis, we believe very strongly at Koinonia that people are created in the image of God, and therefore are entitled to be treated with dignity and respect, regardless of their gender, regardless of their age, regardless of their sexual orientation, regardless of their income, regardless of their intellectual ability, regardless of how they dress, how they smell, any of those kind of things. They are creations of God. And therefore, affirming that in them can be one of the most helpful things that you can do. Encouraging them to engage with the professionals. Maybe even, that means going to the doctor with them, I don't know, but encouraging them to go and encouraging them to be compliant with their medications. There are many, so for example, bipolar disease, which is a mood disorder, in the major depression and bipolar disease are in the same kind of category. Many of them, when they're manic, they don't like to take their medications because they feel good and so forth. So I think encouraging them and encouraging communication with the doctor is really, really important. If they have issues, write them down. So when they come to the doctor, we can talk about those kind of issues. And, maybe go with them again. That's a little bit more radical, but something you all can think about. So treating them like people, just like you would want to be treated. I read about that somewhere. That's a good principle. And then affirming them and not treating them any different than you would treat somebody with a broken ankle, with asthma, with diabetes, or any of those kind of things. So that's just some basic stuff that I wanted to share with you. And I thought I know rather than just keep giving you what I think that you want, why don't we have a conversation and tell me what's on your mind, and then I'll be happy to respond to that. Okay.
Can you see the chat there, Bob? There was a question.
I did. Okay. So let's talk a little bit about, in general, about side effects in medication. No matter what you do, any kind of thing that you do can be viewed as a risk versus a benefit situation, okay? So for example, I don't think any of you would argue that drinking a lot of water is bad for your health, okay? But there certainly are risks, and there's a condition called psychogenic polydipsia, where people actually drink water and drink themselves to death. It can happen. So when you tell somebody you need to drink more water, okay, you don't know if they're psychogenic polydipsic or whatever, but you know that water in moderate amounts is very, very good for you, but in super large amounts is risky. The risks are extremely small. I mean, this disease is a rare disease, and it's usually fairly obvious, but the benefit is good. So to make that, give that advice, drink more water, is a pretty safe thing to do. Okay, now when it comes to medications, then you have to look at the risk of taking that medication versus the potential benefits that you hope to gain from that medication. So the question was sertraline. Sertraline is called an SSRI, selective serotonin reuptake inhibitor. You guys don't care about that, but it is a very, very safe medication. Now, can people have side effects from sertraline? Absolutely, they can. Are they long-term? Most side effects will not last long-term. Many side effects, and I'll often tell people this, when you take a medication and the side effects are minimal, like a little, maybe feeling a little agitated or having a little bit of diarrhea or whatever they are, try and hang in there for a few days to see if they go away, because most of the time they will pass. In terms of long-term effects, I'm not aware of any long-term effects except for, the usual risk kind of thing. When you go to the pharmacy and you read the list of side effects, there'll be about 1 million of them on the sheet there. So that is everything that happened while these drugs were being tested and was reported. So one of the drugs, for example, I forget which one now, one of the listed side effects is the common cold. So what happened there is when it was being tested in a large group, a bunch of people got a cold, they reported it. Now we know the drug didn't cause the cold. Colds are caused by viruses. However, it had to be reported. So there are just generally a few side effects that are more prevalent and that are greater than what we call placebo. So when drugs are studied, they get a whole big bunch of people, they give some placebo, which is sugar pills, and then they give the other people the actual drug, and then they compare what comes up in the two groups. And most of the time, most of those, there's just as many in the placebo group as there are in the other group. But occasionally there's a few more in those kind of things. And so, not all that whole 150 item list of side effects is, is like you're going to get those. Some people think they're going to get all side effects. Okay, how does treatment for anxiety differ from treatment for depression? That's an excellent question. So with depression, the whole idea is to raise the mood. So raise the mood, give the patient more psychic energy, and enable the patient to live a normal life kind of thing. So we use medications that change the chemistry of the brain, of the nerve cells in the brain. Remember now, depression is a disease of the mind. And if you think of the mind or the brain, you can think of it as a whole bunch of electric circuits, like a big computer. I don't know, we used to use the term motherboard. I don't even know if they use that anymore. All connected together and all, to get the final product. So there's a problem in those neurotransmitters, which are the chemicals that carry impulses to travel from one nerve ending to another nerve. It's how nerves communicate with each other. So there's a problem there with those. And the medicines are designed to reorganize that chemistry a bit and to allow the nerves to use different pathways or different circuits. So one way to think of it is you have these negative circuits where there are negative thoughts. And so depressed people have negative thoughts and then positive thoughts. And so you try and rearrange their brain chemistry so they begin to have more positive thoughts and can live in that realm of their brain as opposed to the negative thoughts. Now, anxiety is different. So anxiety is fear-based. So when you look at fear, you think of, have you guys heard of the flight or fight response? So when you're threatened, so say you're walking out your door and all of a sudden there's a huge grizzly bear in your driveway, rearing up and gonna eat you or something like that. So immediately you get afraid and certain physiologic things happen. Your heart beats faster, your eyes dilate, your muscles, the blood flow to the muscles change and so forth. So there's a physiologic response that comes based on fear. This is, old stuff, so that, it's survival kind of stuff. So that, when man was first here and coming out of the caves and he saw the saber-toothed tiger, he ran away, or he stood there and fought to, defeat that tiger. It enables your body. So there's always kind of a heavy physiologic component to anxiety. So people will feel their heart pounding in their chest. They'll sometimes get sweaty, and they feel all this uncomfortable kind of physiologic conditions. And so sometimes with anxiety, we just use sedative kind of that quiets these kind of physiologic effects. And that's all the patient needs, because it's kind of like a feedback loop. So if you feel your heart beating fast, you may think like, oh my God, I'm going to have a heart attack. And guess what? That makes your heart beat faster, right? Because you're afraid now of having a heart attack. And so these cycles build up for anxiety. And so being able to break that enables a person to deal with their fears. And so sometimes things as simple as we use antihistamines to treat depression and so forth. And so they calm down that physiologic response. People feel better, and when they feel better, you're better able to do what you have to do. So we'll use things like drugs that mess around with the brain chemistry. Mess around is not a great way to say that, but change the brain chemistry for depression. We use drugs that blunt the physiologic response for anxiety. Now, interestingly enough, drugs that are used for depression are often quite effective for anxiety. So it's not unusual to use a drug. Someone mentioned sertraline in the past, to use a drug from sertraline, Zoloft, what was its brand name, to treat both effectively. And so many of the antidepressants will also take care of anxiety. Some of the other classes of medicines used for anxiety are things like a class of drugs called Benzodiazepines. So the most famous one of those, I don't want to get too technical on you here, is Valium. Okay, so has anyone heard of that? Like back in the 1960s, every, white middle-class American housewife was addicted to Valium.
My mother
It's
was
just,
addicted to Valium. They
yeah,
just like prescribed it for her like it was candy. It was,
yeah,
yeah.
yeah, yeah. So that was used commonly. The downside, what are the risks of Valium? Uh, Valium is very much like alcohol. It's highly addictive, and it can cause, withdrawal can kill you. So if you're taking Valium, uh, you know, continuously for a significant period of time, and all of a sudden you stop Valium, you can go into delirium tremens, and actually have seizures and die. So it's dangerous to come off of those drugs, and should never be done without a doctor's, supervision. Uh, Another way to think about it is, suppose you came to me and say, Dr. Bob, I'm anxious. I'm really anxious and so forth. And I gave you one of these drugs as a prescription. They work on receptors that are very, very similar to alcohol. So another way of, I could send you down to the corner bar and say, have 3 or 4 beers, and it'll calm you right down. And probably some of you, you don't have to raise your hands or any of that kind of stuff, would know that, alcohol in proper dosing will have the same effect as benzodiazepines, will calm you down. Now, I'm not suggesting anyone here go out and drink to calm down, but I'm just trying to give you some of the drugs we use for these. And then there are other drugs that are specific for anxiety, like buspirone, and they work in various different ways, but basically to blunt that physiologic response. So when you see that saber-toothed tiger or that grizzly bear in your backyard, you're like, yeah, I'm going to get in my car and go to work anyway, so you don't feel your heart pounding and throbbing and all that, and develop that negative feedback cycle. Okay.
Dr. Bob, I was wondering, you were saying that obviously, and this has been history that I know, that the best combination is therapy and medication. Do you have people near your clinic that you can refer folks to for that? And because anxiety actually could be sometimes more difficult to treat, I think, therapeutically.
Yeah. It is chemically. However, I work with, we integrate primary care and mental health care in the same practice.
Oh, okay.
So we've been doing that for years. We just found it's more effective, removes a lot of the stigma. So people say, oh, I'm going to see Dr. Bob. In the meantime, they see Dr. Bob and they see the mental health professional, and they get their meds, and everyone else thinks they're just there for their diabetes or asthma. So it's much more palatable for them. But I have an older gentleman who volunteers with us. He's been in the field since the 1960s. And he says that he can cure anxiety disorders with three therapy sessions. So depression is much harder in therapy to move the needle. It's been my experience. But with anxiety disorders, if the right subject, he can teach self-hypnosis and some of those things in a relatively few sessions, and people can do quite well. So on the other hand, with medications, it's really hard to move the needle with anxiety disorders. Depression, we get really, really nice results with most people. Most people can do very well fairly quickly, and so forth. So, and then everything's patient dependent, so because, you respond in a certain way doesn't mean your brother, sister, wife, grandchild or whatever is going to. So everyone is different. And unfortunately, some people feel like guinea pigs because, you try a medicine, let's say, and you don't get the response. The patient's unhappy. So you try another medicine because these medicines were approved and effective, but we know nothing works on everybody. So from a patient perspective, they sometimes feel like, I'm just a guinea pig. They're just trying stuff, experimenting with me. But that's only because we don't know how any particular person is going to respond to a particular course of therapy. And so, it's always a sense of trial and error to some degree. Now we're getting better. And so there are now tests. They're not commonly available, but they can run blood tests and look at your enzymes, and they can tell from that how well you'll do with certain medications. It's very expensive, and we were only allowed to do it when we just can't find medications that work with people and so forth. So we can get a little bit more selective, do these tests, and they'll say, okay, these meds are likely to do better with this particular patient, giving their internal enzymes, etc. So, yeah, did that answer your question?
Yes. I remember years ago when I worked at CDPC a long time ago, and somebody that we treated with depression and many different medications, nothing ever worked. And back then, the last resort wasn't the enzyme test; it was electric shock treatment.
Right. Yeah.
And I used to think that was horrendous, because I remember one flew over the cuckoo's nest, as opposed to how they perfected that even. And this woman left a week later dancing out of the place after the electric shock, and couldn't get out of bed for 2 months.
Yeah.
So I was flabbergasted.
It works. It works. It's barbaric, and I, as a medical student, we had to accompany when we were on psych, we would accompany our patients down to the operating room where these, they put the electrodes on the head, and the person would look like Frankenstein, and they'd shock them, but it works. It can be very effective. Barbaric, to think about, but very effective. You're right. And we only do that in select cases, sometimes with older people tend to have, resistant forms of depression and so forth. So we're careful about that. One of the things I want to say that might be important in dealing with people that suffer from these maladies, you want to get them into remission, and you want to do that as quickly as possible. So if I have 2 patients walk into my office, the first one is, say, a 20-something, first time depressed, and basically a healthy person, and, not on, 6 or 8 medicines and blah, blah, blah. And, not a victim of satanic ritual abuse or any of those kind of things. And I treat that person, that prognosis is excellent, excellent. If I see a patient who comes in who's 50 years old, and they say something like, Dr. Bob, I've been depressed all my life, and I can't look back and point to a time in my life when I felt, not depressed, normal, or whatever, happy. That person is extremely difficult to treat, because it's like, think of those circuits in your brain. I liken them to dirt roads with traffic. So, and you have negative dirt roads and you have positive dirt roads. And when you're depressed, you have a lot of cars going on the negative dirt roads. What happens? You wear in ruts, right? And so over the longer you're in those negative circuits or driving over those negative dirt roads, the deeper and harder to get out of those ruts become. And so that's another reason why when we start to treat a patient for depression, we usually will treat for 9 months to a year at a minimum. Because if you stop the medicine sooner, even though they're doing well, the tendency is to fall back into those old ruts and to take on those negative kind of, thought pathways again. So getting them out of the depression into remission, getting the anxiety quelled, the sooner the better, and they'll do better. If they come in and they've been 80 years old and they've been depressed all their life and nothing works, well, then we better get out the shock paddles, because your chances of getting them into remission with, the simpler medications are probably not good. So identifying it early and getting help early is huge. So if you can encourage that, it would be huge.
Dr. Bob, is it bad or unhealthy, mentally unhealthy or whatever, to stay on the medications forever?
No. Most of the cases, no, it's actually better. What I tell people is, if it's a single episode, first treatment, first bout of depression, okay, and you want to come off the medicines, because many people don't want to be on any medicines, whether they're psych medicines or anything, right? I say 9 months to 12 months, and we can talk about it and so forth. If they've had a relapse, so say they had a bout of depression, they were started on a medicine, they went into remission, and now they stopped the medicine, and now, who knows, a year, 5 years, 10 years later, they relapse, then it's less likely, I would be less likely to encourage them to come off the medicines. And if people have had multiple relapses, I would say, you really need to stay on these medicines for life. Now, with a lot of the medicines we use, they are safe, but there are certain things that tend to be problems. Number one is weight gain. Being on the heavier side of things, that's one I'm particularly, tuned into. The other is sexual side effects. So, and they can range from delayed ejaculation, inability to achieve an orgasm, those kind of things. And when people are depressed, honestly, most of them early on, they don't care, so what, I'm not anywhere near even thinking about sex or anything like that. But then as they get better and longer, that can become a stumbling block. And so clear and honest communication with the doctor, because sometimes people are embarrassed to bring that stuff up. And so we can't fix it if we don't hear about it. And there are other medications sometimes that we can substitute that don't have those particular problems. So we want to always be conscious of that. But if you need to stay on these medicines your whole life, so be it. We're leaning more and more towards this, especially even with treating addictions, where we will put a patient on Suboxone, for example. And rather than taking them off at some point where the risk is they could relapse and die, we would prefer to keep them on their whole life. Now, I understand if there's disagreement with this. I'm not speaking, black and white kind of things. We have to work with the individual patient, and we try and do that and figure out where they're at, where they're coming from, and then decide on a plan of treatment that's in particular best for them. And there's no cookie cutters, nothing, it works for everybody. So we have to tailor it to the patient. And if a patient disagrees with me, I kill them. No. If a patient disagrees with me, that's okay. I'm not threatened by that. I want to see the patients do the best they possibly can. So as long as we're honest and upfront and we work together, that's not a problem at all. So I can handle different opinions.
There's one more question in there that somebody gave to me, and you might have kind of answered this. I don't know. Can someone have depression, then be fine for a period of time, and then have the depression again?
Yeah, absolutely. It can come and go. Normally it doesn't, but I've been around long enough now. I've seen about everything. So some people can spontaneously just get out of it and can go into remission for a while. Who knows? Maybe it's, they're in a more positive situation. They have support around them. They have, loving relationships and things like that. And for whatever reason, they respond to that, and it creates the proper chemistry in their brains, and they get better. But then they can slip back into it. There's also genetic predispositions to this. So, look at your family tree, and if there's, especially things like bipolar disease, and but even unipolar depression tends to run in families. So you may be more genetically predisposed to developing depression and anxiety, and that's something that, you can take up with your doctor. So there's all kinds of variations here, as many as there are people.
We want to honor the time. So I think the last thing I want to ask you is to maybe give some advice on resources that are available in the community. Yeah. Like, where should we go? So, I mean, we can all call you, I know, 24/7.
Yeah, No, you can, that's for sure. Pastor Sandy, I wish I could say they were great. But unfortunately, it can be really, really tough to get the help that you need. You should start with a family doc that you have, a primary care person. If you don't have one of those, that's a really important thing, to have somebody that you can relate to, that knows you and will advocate for you, because chances are, they know things that you don't know, and they can help you and so forth. But what if, someone wanders into the church, you don't know this person at all, and you find out that they have this, what do you do with them? Okay, so it depends. What are your options? Well, first, is it an adult or a child? So children do suffer from mental illness. So you have to be aware of that as well. So they do get bipolar disease, they do get depression. Teenagers often, get depressed, and suicides can be high amongst teenagers. So be very, very, aware of that, if you have younger people in your congregation. There's always the county mental health department, which will take people without insurance and so forth. They are honestly overwhelmed, but they have a pretty good children's department. So, and they have this kind of application. It's just a uniform application that people fill out, and they'll look and see, where they can bring help. So a resource would be a family doc, would be the Albany County Department of Mental Health. Now, in the private area, engaging with a therapist, or say someone wanted to do counseling and that kind of thing. Another resource would be, for example, CDPHP has been a leader in this area. So if I have a patient with CDPHP, they have a whole task force of people that I can call them up and say, hey, I'm working here with Joe, he's a CDPHP member, he's got a problem, we need to find a therapist or whatever. And then they will do the legwork. And it's people that participate with their insurance most of the time, unless they don't, in the last couple of weeks or so, which can always happen. In a time of crisis, okay, somebody's acutely suicidal or homicidal, or they're just so disorganized that they can't cope with life. Bring that person either to the emergency room, or call the mobile crisis unit, which will come out into your church or your home or whatever the situation is, evaluate the situation, and determine if that person is appropriate and what services are appropriate for that person. So if you, get in that bind, think of crisis. And I've had crisis in my family. I mean, let's be real, there's no shame in that. Get the help you need. And oftentimes, if people get over this hump, whether it's depression, anxiety, whatever is going on, there's good treatments, good medicines, they'll do well. But it's a tragedy when someone commits suicide. It is a tragedy. And and think of the people left behind. Sometimes they almost never recover. So get the help. When in doubt, I'm reachable, 24/7, 365 most of the time. I mean, I just took 4 days to take my wife to Jamaica before she had her knee replaced, and people were calling me down there, and it was fine. So if in doubt, call me, and call the office, and I'm reachable 24/7 through the office, kind of thing. And I'm seeing a note from Teresa, which we'll talk about later.
And I'll reiterate that one, like a little self-care. Turn your phone off. We have 911 for a reason. So does anybody have any last minute quick questions? And then if not, I'm gonna turn off the recording and we can chat. Okay. I am